Folks, welcome back. Concluding our day of speakers before we start the panel discussion is Dr. Joelle Donofrio-Ödmann. Dr. Donofrio-Ödmann is assistant professor of pediatrics and emergency medicine at University of California, San Diego. She completed her pediatric residency at USC LA County and then a PEDS EM fellowship at UCLA Harbor Hospital. And then after that, to focus on her niche in pre-hospital care, she did her EMS fellowship back at UCSD, where she currently practices. She does a lot of pre-hospital work in San Diego. She's chairwoman of the California EMS for Children's Technical Advisory Committee. She's also deputy CMO for San Diego Fire and Rescue. She's the EMS medical director for Rady Children's Hospital of San Diego. And she does quite a bit of research focused on out-of-hospital cardiac arrest in pediatrics and also pre-hospital pediatric resuscitation. So Joelle, thanks for joining us out here on the East Coast. I hope you were able to sleep in a little bit, and go ahead and take it away and tell us some updates about pediatric cardiac arrest.
I woke up very early so I could make sure to attend all the different lectures and learn as much as I could about cardiac arrest this morning. Tough acts to follow. So let's talk a little bit about kids, one of my favorite populations. But let's follow up that OB talk first. I have no conflicts to disclose, unfortunately. We're going to talk today about neonatal resuscitation, why neonatal resuscitation is not PALS. We're going to talk a little bit about pediatric cardiac arrest, what to do when you get ROSC, some pre-arrest considerations, summarize it, and then wrap it up. All right, so medics bring a 29-year-old G1P0 female to the doors of your ambulance bay. She's having shoulder dystocia. It's a difficult delivery. You do McRoberts, some suprapubic pressure, and you deliver a limp blue baby. Why does it matter how you resuscitate the newly delivered? Because they're aliens. The newly delivered are transitioning from a water-filled, low-oxygen environment to an oxygen-rich air environment. They have to fill their lungs up with air. They need to have their breathing reflex triggered, and they need to change over their circulatory shunts. So neonatal resuscitation, the resuscitation of a newly delivered infant, is alien resuscitation from water to air environment. So the first thing that you're going to consider is equipment. If you know that this is coming and if you get a call from EMS, or if you see that you are delivering a patient, you want to make sure you have your equipment, your warmers, your hat, your blankets, your suctions, things for airway access, etc. Have it ready and prepared. If you have a neonatal team, go ahead and call them. If you don't have a neonatal team, get your RN and RT to come help you. Then the baby's born. And the big key question here is this baby going to mom, or does this baby need to be resuscitated? And there's some big key questions for this, and it's not Apgar. Your questions are, is the baby relatively full term? Looks like a normal baby. They're crying, and they have good tone. If the answer is yes, 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 you got to bring the baby to mom, do skin to skin, practice the latch, get that golden hour of breastfeeding latch attachment. This is not your Apgar. So continuing on, let's say your baby doesn't have good tone or isn't crying. Your first step, hello, seriously, welcome baby, welcome to the air world. Let's get you breathing. Warm, dry, stimulate. Don't rub the skin off, don't break bones, but you're really trying to get this baby to vigorously stimulate and go, wake up, welcome to the air world, let's get you breathing. Then you assess what's the heart rate and are they breathing? And the are you breathing question is really important. So what happens normally during delivery is you don't breathe intrauterine. You don't have any air in your lungs. You're in there, you're getting everything from mom. You have a vigorous stimulation when you're going through the vaginal canal with labor, and that causes the reflex to begin to breathe. It's fantastic. It's normal. Most of us did it. Problem-free. However, if you have a difficult delivery, prolapsed cord, shoulder dystocia, if there's circulation getting cut off to the baby, the acidosis rises and you get secondary apnea. And why this matters is what they found is for secondary apnea, every minute of poor perfusion to the baby leads to about 5 minutes of needing to help the baby breathe before they start breathing on their own. So if the baby comes out and you warm, dry, stimulate, and they don't breathe, it means there is a period of low flow state to the baby and you need to resuscitate. And depending on how long that baby had poor perfusion, you might need to give that baby rescue breaths for 5, 10, 15, 20 minutes before they go, I'm supposed to breathe. I'm in the air world. I need to do what I need to do. So resuscitate very early. And by resuscitate, I mean breathe. Help that baby breathe for apnea. So warm, dry, stimulate. Come on, baby, breathe, breathe, breathe. And then you look at, are they breathing? And then you look at their heart rate. Is it fast? Or is it slow? What we do, if you have enough hands on deck, is we'd actually, before you could have time to put the probes on, have someone palpate that umbilical cord. It's one of the best pulses you can possibly get, and have you pat it out. If your heart rate is under 100, if it's slow, and you don't have to count the rate, if you hear it's a slow heart rate, you need to bag the baby. If the baby's apneic, you need to bag the baby. Throw on a monitor so you get that continuous feedback on how's the heart rate, and continue to flow. Now, every time that heart rate starts to slow down, so if you start to bag the baby goes from slow to fast, and then you start to hear it slow down again, you need to check your breathing. Do you have a good seal? Do you have good chest rise? How's your technique? Most often what you'll see is that you've gotten excited by a few other things, that the rescue breaths aren't as effective, the heart rate starts to drop, you correct your ventilation, the heart rate goes up. This is your most important feedback. If you're needing to breathe for a while, throw an LMA in. This is when you start to think about, do you need to intubate? Do you need to do more of definitive advanced airways? And then when the heart rate is less than 60, despite good ventilation, you're going to do chest compressions. When you're starting your chest compressions, you're going to get your access, continue good breathing, reassess, and these are every 30 seconds you're reassessing. If after 30 seconds, their heart rate is still really low, you're going to start your medications. And it's easy. Cardiac dose epi. If they're hypovolemic, 10 cc per kilo of normal saline. If there is a significant amount of blood loss, like you had cord rupture, you're going to give 10 per kilo of PRBCs. If they're preemie and you're aggressively bagging, you can blow a pneumo. So if you see a tracheal deviation, if you're hearing asymmetric lungs, a cool trick is grab your otoscope and transilluminate the chest. You'll actually see if there's a pneumothorax and if you need to do a needle T. These are very low likelihoods though. Now, if you look at the image, you'll see this says 2015 and 2020 because, ladies and gentlemen, it hasn't changed, which is fantastic for us. So it's all about breathe, breathe, breathe. Please breathe. Make sure we have a good heart rate. If the heart rate's too low, check your breathing. If the heart rate's even lower, compressions, and then your medications. And it's every 30 seconds, check, check, check. Now, what about the Apgar? Everyone loves to talk about Apgars. What was the Apgar at the birth? You notice I haven't talked about the Apgar because the Apgar occurs at 1 minute. At 1 minute, if you have a baby who needs resuscitation, you need to focus on the resuscitation. You need to get the baby breathing, perfused, warm. Your Apgars can be an afterthought after you've successfully resuscitated the baby. The 1 minute Apgar hasn't been found to have long-term poor outcomes. It's your 5 and your 10 minutes. So focus on resuscitation. After the fact, think back and go, okay, after we started bagging the baby for about 30 seconds, how did that baby look? So speaking of breathing, Remember, the neonate is transitioning from a very low oxygen content. They have fetal hemoglobin. They are used to having that low oxygen content. So when they transition to the relatively high oxygen content air environment with their fetal hemoglobin, they're more susceptible to oxidative harm. So what that means is that when we resuscitate the newly delivered, start with room air. Give them positive pressure because they really just need to pop the lungs open. If on room air, you're still having issues, increase to 30%. After that, if you're still having issues, you can increase to 100, but you're going to start low and then work high. There's nice newer literature coming out showing LMAs work in this age group. So don't be afraid, slap that LMA in. It'll give you great oxygenation, great ventilation. The key is, and this is really important, I'm going to pause so you can really pay attention to this. Do you have the equipment to do a neonatal LMA? When they did the pediatric readiness survey throughout all the US emergency departments, what they found is the most likely missing pediatric equipment was the neonatal equipment, the neonatal LMA, the neonatal laryngoscope blade, and the neonatal end-tidal CO2 monitor. So you should go back to your ER and just make sure if you have a newly delivered infant who needs to be resuscitated, do you have the equipment there? Next up, special caveats, temperature management. This is my beautiful COVID daughter born in June 2020. And as you can see, she has the warmer, she has a hat because you tend to lose a lot of heat. And the thing you can't see very well here is you have double blankets. So you want to have everything prepared so you can warm, dry, stimulate. With that, you have a wet blanket, you can throw that off, and then you'll have a dry blanket underneath that you can wrap them up to keep the temperature. You want to keep them warm, or if they're born out of hospital, you're going to want to work on getting them warm. You're going to want one of those little silver pads that connect to their abdomen because you don't want to cause some fevers with your heating implementations. On the right, you'll notice a little preemie baby in a bag. That is because the polyurethane bag can reduce heat elimination significantly. It saves the skin, prevents evaporative losses. It's cheap, it's easy. Make sure you have one in your OB kit. The key is that you're going to pull it up to their armpits. Obviously don't cover the airway or cover their neck, and have it available and ready. We use it in all the NICUs. We even use it for EMS. So keep the baby warm, prevent heat losses in your preemies. And then here's an interesting caveat. There's certain babies that get cooled. So we do therapeutic hypothermia if you are, the lowest cutoff is 34 weeks and within 12 hours, but the optimal cutoff is if you're 36 weeks gestation, within 6 hours, if you induced therapeutic hypothermia, you have increased odds of neurointact survival and like just impressive outcomes. Why this matters in the ER is to determine if they're at risk for hypoxic ischemic encephalopathy and whether they're indicated to get therapeutic hypothermia, like you have really bad Apgars, you need a 1 hour blood gas. So if you have a baby that you're resuscitating, get your blood gas and consider early transport because these patients might need therapeutic hypothermia, and it's one of those things to initiate sooner rather than later. All right, meds. It's easy, right? Epi, saline, blood, glucose, that's all you need when you resuscitate the newly delivered. It's not a complicated medication scheme. But the complicated part is how do you get those medications into such a tiny body? If you have the time, there's great videos. This is a New England Journal of Medicine video about how to do an umbilical venous catheterization. As an ER team, you're just doing resuscitative UVC where you're putting in just enough to be able to pull back a little bit of blood, push meds. You need to make sure you have the equipment for that though. And if you're not comfortable with it or you don't have the equipment, IOs work. It's what we teach our medics is IO, IO, IO. There's newer literature saying all neonatal units should have access to an IO. Now, we don't have data showing which IO, where to place the IO, and how long the IO can stay in, but there are reports of babies, neonatal resuscitation kids, about 24 of them, where they received the IO and they had good outcomes. So, to resuscitate, the newly delivered, it's different. Warm, dry, stimulate. If there's a little bit of retractions, maybe some central hypoxia, but they're breathing, have a great heart rate, you can do some blow by. But then it's all about the heart rate. Is it fast or is it slow? And is the baby apneic? And you're giving rescue breaths. You're repeating that, checking if the heart rate's really slow, you're doing compressions for 30 seconds. Then you're reassessing. If it's still really slow, you're giving epi, considering blood saline. Now, the difference for the neonatal resuscitation is at some point, they're going to get the fact that they're in an air environment, they should be breathing. And so it might be after 5, 10, 20 minutes of you doing rescue breaths that the baby goes, oh my gosh, and starts breathing on their own. Their heart rate goes up on their own. When the heart rate's over 60, you don't need to do compressions. When it's over 100 and they're breathing on their own, you don't need to ventilate them anymore. You have successfully transitioned them to their air environment. Now notice when you look at all this, our only thing we're measuring is the baby breathing and is the heart rate over 60 and over 100. That's it. This is opposed to our no longer newly delivered, aka the air breathers, who get PALS, name that dysrhythmia, shockable, not shockable. They have a whole bunch of different medications. So the newly delivered are a special population. They're high risk, they're low frequency, and it's very appropriate that I gave this talk after the last talk discussing obstetrical complications. If you have the things I'm showing in the pictures, OB trauma, shoulder dystocia, cord prolapse, if you're having to do perimortem hysterotomies, you're going to need to do neonatal resuscitation. So if you keep these together in your brain, scary OB stuff with the resuscitation of the newly delivered, they go hand in hand. You're not going to resuscitate a newly delivered without having had a mom who just had the baby. Oop. Educate together and train together, both complications with mom and complications with baby. Keep mom and baby together. All right. This is my beautiful daughter who I showed you the picture of. She actually did get resuscitated. This is her a few weeks ago, trying to decide if she wants to be a doctor or a fire chief. So let's talk about some air breathers. Let's start off with a case. This is a 12-year-old male who is with his mom at the beach in San Diego, out surfing. He took a fall, went under the water. Mom went, pulled him out, saw it immediately, pulled him out. He was pulseless apneic. She started to do rescue breaths and chest compressions. Lifeguards arrived. They took over compressions. They placed an OPA. They put him on the AED, which said shock. They shocked him twice. Our fire and EMS crews arrived. They found him pulseless, apneic. They defibrillated him after finding him in VFib. They gave 2 rounds compressions, 1 dose epi, got return of spontaneous circulation, and headed to the Children's Hospital. So if you work in the ER, you probably know EMS communication isn't that great, and getting EMS paper records is really difficult. So they showed up, they gave the verbal report, but in the interim, during all this stuff happening from the beach to the ER, he got epistaxis, and so he had a bloody airway. So he got activated as a trauma. While they were told he got shocked numerous times, they went, we actually think it was probably an injury from a wave crash and him hitting his head. And so they treated him as a trauma patient, started 3% for cerebral edema. He was hypotensive. They started pressors and admitted him to trauma in our pediatric ICU. So an interesting thing in our city is we actually capture all of our AEDs. So we have Project Heartbeat, which is an AED system. So all of our AEDs, if they are deployed and they defibrillate, we automatically send one of our people to the scene to get the AED, to get the recording, look at it, and also provide debriefing at the scene for any of the bystanders. So I get a phone call immediately after they go to the site, they get the AED and they look, And they call me and they say, Dr. Donofrio, check out what this AED showed on that 12-year-old. He had torsades. So we were able to take this AED, I brought it up to the pediatric ICU, showed it to them. They started a mag drip. They got a cardiology consult, sent genetic panel, and it turned out he had catecholamine polymorphic VTAC from a genetic mutation. 11 days later, he walked out of the hospital neurologically intact. Gives me goosebumps every time I say it. So why am I using this case as an illustration? It shows you the continuum of care, from bystander CPR that mom gave, the AED applying the defibrillation, our lifeguards showing up, fire, EMS, going to the ER, to pediatric ICU, and the need for the closed loop communication. All of this together led to this patient's neuro intact survival. And having EMS data led to appropriate management and care and identification of cardiac etiologies. Now, let's talk a little bit about pediatric cardiac arrest. I think everyone gets nervous when they have an arresting kid come in. What I'd like you to know is you take care of cardiac arrest so much more than pediatric ER physicians do. Kids don't die very often. It's very infrequent. So use the skills that you have to help the kids, because you are very good at cardiac arrest care. Heck, you're at this conference learning even more about it. All the things that work for adults work for kids. High quality compressions. You want to push hard, push fast, have appropriate recoil at a rate of 100 to 120. You want to adequately ventilate. You want to have good end tidal CO2 tracings. You want to make sure that you have good chest rise when you have it. And the rate basically changes, but the easy way to remember it is breathe, release, release, breathe, release, release. So if you get nervous and you have someone on bagging, you just go breathe, release, release, breathe, release, release. It's a mantra. Early defibrillation works for kids too. If you have a shockable rhythm, shock it, just like adults. For access, focus on early access. I say IO, 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 because tibial, femoral, humeral. Know your sites of IOs. It's possible, and I have been in a scenario where I had one of my colleagues at the feet. I was at the head of the bed. We had a failed tibial, left, right, femur. I got past the IO drill, and we got a successful humeral. Know different ways that you can access and get that first dose epi on board ASAP. I know Dr. Slovis was talking about epi and all the controversy of epi. Well, in kids, what we found is that timing to first dose epi is associated with ROSC, survival to discharge, and survival to neuro intact status. So get your epi on board within 5 minutes. So what about the airway? Out of hospital literature and in hospital literature with pediatric cardiac arrest really show you don't gotta put a tube in while the patient's arresting. You can wait for ROSC. They actually found better odds of ROSC, survival to discharge, and neuro intact survival when intubation was held off until after they achieved ROSC. So bag, throw an LMA in. You want to make sure you have good oxygenation, ventilation, and perfusion, but you don't have to worry about the tube until you actually hit ROSC. Now, the caveats on the pediatric intubation, obviously choose right tube, right depth, right blade. You want to make sure that you have instruments to secure it, both to the mouth and for the head, because any shifting of that little pediatric head can cause an intubation or a main stem displacement. So secure tube, secure head to keep everything in place. And don't be afraid to use a pediatric app. There are many different types of apps that are successful for showing you what kind of dose you need, what kind of tube you need. The key is use your app frequently. Be comfortable with it. You don't want the first time you pull out the app to use it to be when you have a cardiac arrest in front of you. So use it frequently, be comfortable with it. You can use it during your codes. It's very easy. So you do fantastic compressions. You have great ventilations. You throw an LMA in. You get a pulse back. Now what do? You have ROSC, you want to keep ROSC. What the guidelines recommend are targeted normothermia. We don't do cooling, we do prevention of fevers. Get your perfusion up with epi or nor-epi. Keep the patient oxygenated, ventilated with an end tidal of 35 to 45, and continuous EEG to look for subclinical status and treating the seizures as needed. Now, if you're looking at this, you go, perfusion, oxygenation, and ventilation, preventing the H-bombs. It sounds a lot like the EPIC trials for traumatic brain injury. It's all the same for everyone. Prevent hypotension, hypoxia, and hypocapnia in order to improve your outcomes for adults and kids. Brain trauma and cardiac arrest. So what about pre-arrest conditions? There are 5 pre-arrest conditions that you should be aware of. 1, septic shock. If you're giving fluids and they're fluid refractory, give pressors. When you're giving pressors, consider steroids. Don't wait for them to fail the pressors before you give the steroids. This is one of the newer changes. For hemorrhagic shock, kids are just like adults. Massive transfusion protocols. You want to have balanced blood resuscitation. Opioids, again, just like adults, naloxone. You cannot overdose a pediatric patient with naloxone. You can give it to any age of child. This is unique. Kids can have persistent pulmonary hypertension, and they can end up having crises from these. So if you have a kid with persistent pulmonary hypertension who is coming in and they're critically ill and nothing you're doing is working, try inhaled nitric oxide and prostacyclin. It'll help decrease the hypertension in the lungs, open things up, and improve perfusion. And last but not least, consider ECMO early. So ECMO was actually developed in the pediatric population for our cardiac patients. Children's tertiary centers have been doing ECMO for years. They're very comfortable with it. If you have a critically ill cardiac kid, myocarditis, stage single ventricle repair, refractory pulmonary hypertension, consider transfer early to a pediatric ECMO center. So to wrap up all of that chaotic talk, consider neonatal resuscitation an obstetrical emergency. And remember that resuscitation of the newly delivered is all about breathing and heart rate. You're helping transition from the liquid to the air-based environment. For pediatric cardiac arrest, the skill set you already have for adults is exactly the same. Do high-quality cardiac arrest care. When you have ROSC, keep ROSC. And know your pre-arrest caveats: sepsis, hemorrhage, opioids, pulmonary hypertension, and cardiac etiology. And don't forget, kids get ECMO too. So thank you so much for this opportunity, and feel free to join me in the Twitterverse or listen to our pediatric EMS podcast.
All right, folks. Well, thanks so much, Joelle. Thank you very, very much for that outstanding presentation. I'm sure we're all going to be seeing you on the speaker circuit quite a bit in the coming months and in the years.